gentleman who called saying that he was feeling lightheaded when getting out of bed. And that morning, he had almost passed out. He also didn't have a ride, and he said he was more than an hour away from his closest ER. So by talking to him, reviewing his chart, the nurse and I were able to figure out that the dose of his prostate medication was increased about a week ago, and that's really when his symptoms started. Now, understanding that this is a pretty common side effect of that medication, we were able to advise him to hold his next dose, take in plenty of fluids, and then provided him education about when to take this medication to best avoid those side effects. And then when we checked up on him a couple of days later, he was feeling great and was so thankful that he didn't need to figure out how to get to an ER and then spend hours in a crowded waiting room. So look, teleemergency care is perfect for veterans who need medical advice right away, but don't have a condition that needs to be treated in person. Our providers can evaluate veterans over a video visit or over a phone call, and then we can decide if that's something that truly needs an ER visit or if there's options available to treat the veteran right at home. And all veterans need to do this is call VA Health Connect. And on top of being able to speak with the triage nurse and possibly obtain tele-urgent and tele-emergency care services, VA Health Connect also does other
What's up,
things, like
everybody?
provides veterans with the ability
We
to
are going
schedule and
to
reschedule their
stream the VA press conference, and if anything said that sounds a little crazy, which you never know what happens with these things, we'll comment on it. All right, let's go. It just started, so.
And actually, what's even more awesome is that one of the key innovators of tele-emergency care is himself a Marine veteran. Mr. Josh Geiger, the Director of Operations for VA's National Emergency Medicine, was instrumental in spearheading this service to help
Good
bridge a
morning.
gap
How's it going?
in a care that he and his fellow veterans were experiencing. It was
Thank you
truly
for being a
under
member,
Josh's
Tom.
leadership and persistence
Nuclear.
in
Ooh,
combination with
that reminds
groundbreaking
me.
work by clinicians like
And Soul
Doctors
Moon Rising.
Janine
Nuclear, I
Smith,
need to make you
Valerie
a mod.
Bahari, Valerie Seba, Paul Kim, Matt McKinsey, Reshma Patel, Kim Trinquada, Lisa Zhao, and many others, that tele-emergency care is now available for veterans throughout the country. And knowing that this program emerged from a veteran trying to increase access to care for his fellow veterans honestly makes doing this work so much more meaningful to me and to many of my VA clinicians. So again, anyone who's interested in learning more about tele-emergency care and the other services that VA Health Connect can provide can visit va.gov/Health Connect. Now, going forward, we're going to be working incredibly hard to make this service even more accessible to veterans, no matter where in the U.S. they live. Because look, every veteran
Lori, good.
deserves to feel like they have
Hope
a
that
medical
worked out for you.
professional in the family. And
Thanks
now
for being a
all they
member.
have to
J
do
Sweep,
is
what's
pick
up?
up the phone and call us, their VA family. Thank you so very much.
I just made you a mod, so you should be able to do something.
Thank you, Dr. Patel.
Yeah.
Great work. It's great to be with you all today. When the PACT Act became law, VA expanded healthcare and benefits to millions of veterans nationwide. But it's one thing to make all of those veterans eligible. It's another thing to actually get them in the door. So President Biden, Secretary McDonough gave us a mandate on day one. Reach out to every single veteran and every survivor who is newly eligible for care and benefits and make sure they
Congrats.
get what they earned. Since then, we've embarked on the largest outreach campaign in the history of VA. We've hosted thousands of events across the country, including at places like the largest motorcycle rally in America, major sporting venues like Yankee Stadium, and even local barbecues that we hosted in the cities and towns where veterans live. For the first time in VA history, we've sent text messages to millions of veterans who are unaffiliated with VA, encouraging them to come to us for the very first time. We've executed a nationwide advertising campaign, ranging from media to billboards to TV, informing veterans not only about what the PACT Act is, but why it matters to them. We've even worked with everyone from major pharmacies to Congress to prominent influencers to spread the word. And all of this work has had one core idea. Wherever veterans
Not
are, that's where we
that.
want to be. We want to build a department that fits into veterans'
Not that type of
lives,
stream.
rather than asking veterans to make their lives fit into VA.
Live
Because we
Q&A
know
though.
that veterans who come to VA are proven to do better, to live healthier lives. And the best way to bring them in is to meet them where they are. Now, as a result of this campaign, we've seen record increases in applications across the board. For benefits, more than 4.7 million veterans have applied since PACT, an all-time record and 38% more than the previous 2 years. For healthcare, 747,000 veterans.
For
have enrolled
benefits,
since
here, let
PACT,
me.
a 31% increase over the previous
For
period.
benefits, I
And
believe
most
there's about a
recently,
70, 75-ish
for memorial
percent
affairs,
service connection rate, which is
128,000
pretty solid.
veterans
PACT Act is
have applied
good.
to
I hate
pre-confirm
hearing
their
about it all
time
day, every
burial
day,
in a
but
VA cemetery since PACT, another
sure.
all-time record. And while these numbers are important, it's the stories of these veterans that remind us all why we're doing this work. For example, I recently heard a story of a veteran down in Texas named Ashton Hamilton, who served in the Air Force from 2008 to 2010 before being medically discharged.
I'm
She'd
going
never sought
to
any
try
assistance from
to
VA
upload a
before.
video at
In
the
fact,
same
she
time
didn't
of
even
doing
consider
this.
herself a veteran.
So
But this
if
past
anything
summer,
crazy
her
happens, that's why.
stepfather, a veteran himself,
Option
sent her a
C,
flyer
brother.
for one of our
Thank you.
barbecue-style
Appreciate
events
that,
down in
big dog.
Texas. So she decided to drop by.
Always on call.
At that event, she not only
Every
learned that she
time.
was
Thank you.
eligible for VA care for the first time, she was able to enroll on the spot. Later that day, she said, "This was just what I needed to start using the VA benefits that I didn't even know I had earned." That's what those events are all about. That's what this outreach effort is all about. Finding veterans like Ashton and getting them in the door and getting them what they've earned. Now, partly as a result of this effort, as the Secretary said, we're now delivering more care and more benefits to more veterans than ever before in the history of VA. And we're going to keep it up. So,
dude, I just
our
made
message to all veterans is this: get what you've earned today by visiting.
I just made a video about how the VA overuses that, and they like to use that whenever they're in, like when someone asks them a tough question, like in Congress or during one of these live conferences. They always use that quote over and over and over and over again. That's what makes me not like it. You know, the good doesn't outweigh the bad. The bad doesn't outweigh the good. It's both things are true at the same time. VA does good things. VA does bad things.
We'll open the floor up to questions.
And here's our favorite
Leo.
part. Leo
Good to
Cook.
see you.
Good to be seen. Thank you. Thank you, Mr. Secretary.
I think
for
that's his
doing
name.
this. Question about what Adam was just talking about in terms of the
Leo
increased
Shane,
benefits
sorry.
and the increased workload that's come from the PACT Act and the folks coming in. You guys have asked for $12 billion in next year's budget. It looks like that's not going to be resolved until December, maybe even later. Is there any concern about that surge and that workload over the next few months here, 3 months here? Can VA keep up with it, or are we going to start to see some issues with hiring, with being able to process these benefits, with getting folks medical appointments?
It's on the
Leo,
VHA
thanks very
side of the
much for
house, not the
question. Let me
VBA
just,
side of the house.
Before answering your question, I want to say two things. One, it's really, really good to see you. Two, Adam takes that outreach effort so seriously. I just want to call your attention to one thing. He had an opportunity to highlight a very major event we just did at Gillette Stadium in Foxborough, Mass, with the Patriots. But he didn't highlight that. He highlighted an event we did at Yankee Stadium with the Yankees. The dude is a Red Sox nut. So this is how seriously Adam and our team takes the outreach. And I really commend him for his awesome work. So you're right that the bill that has now passed both House and Senate, the continuing resolution, did not carry the anomaly for VA. We're continuing to work with OMB and with Congress on that. We'll be answering additional questions, I'm sure, from members throughout the course of the rest of this month and into during October. And then we hope when they come back and take up the rest of the year funding for FY24, which will have to be resolved by December 20th, sorry, FY25, which will have to be resolved by December 20th. We're hopeful that we see an anomaly there. In the meantime,
Blah, blah, blah.
we'll
I'm hoping
continue
these
to
people ask some
provide,
really good questions, man.
world-class care.
We'll see.
And we'll continue learning about hiring decisions. That's one of the issues that will continue to be at the heart of how we manage and execute our budget.
My wife
over the course
texted
of
me.
this year. Our teams, you'll recall that when I testified last spring, Congress expressed concern about our staffing levels anticipated in the advanced appropriation. we took those concerns to heart in the context also of the very aggressive outreach that Adam just briefed. And we've determined that to continue to provide the kind of care that we want to provide, we should have a different end strength number. So we're hopeful that Congress will help us get to that outcome when they take up the when they take up the full year funding for VA and other agencies at the end of December. In the meantime, I am, you preface your question with, are there any concerns? And I think I've said to you guys in this room, anytime you ask me a question, is there any concern? My answer as a nervous anxious character is going to be, the answer is yes, I always have concerns between now and December 20th, and then we're hopeful that we'll get the investment that we need.
I've been out of practice for a little bit, so I should know better than that. Are there any concerns?
Yes.
But with the,
I
when
don't
you
know,
say
man.
manageable,
It's government
you've been
contractors.
looking at this increase, and you've given us some numbers here since March, seeing
Yep.
more folks coming in and everything. So are you starting to hit any concerns
Yes.
with the workforce?
It'll actually be
numbers where
November
3
1st,
months
but
from now,
yes,
you really need those
that
folks in
passed.
place,
We're
or is
good.
that
They're talking about
raising that at
VHA right
something
now.
of a longer term by the end of the year? We'd like to.
I'm really happy to report, and we've been talking to Congress about this, and we actually should probably just get you guys these numbers. I'm sure Terrence can get them. In terms of
You can file all those.
all that increased access that Adam just briefed, we've seen at the same time continued strong performance and reduction of wait times and increased access to care across many of our specialties, across primary care, across mental health, and then across the system. So right now, as I look at the system, it's performing very well. More care to more veterans, and doing that with reduced wait times, for example. And ultimately, as I said in my opening comments, with the highest trust scores that we've experienced since we started scoring.
I haven't used them for dental.
But
Thank you for being a member,
we are
though.
going to, we're asking for the additional funds for a reason, and we'll continue to
Appreciate
answer
that.
questions about that, and then I'll be hopeful that we'll get this resolved by the end of the year.
Thank
Okay.
you, and thank you and your staff for kindness over the
You
last
need to
few
do a
months.
supplemental if you were
Appreciate it.
denied.
We say this all the time to each of you in this room and those of you on the screen, at least most of you on the screen. I'm just kidding. You guys help us do a really important service, which is explaining to veterans, their families, caregivers, what is the right to expect. So thanks for doing what you do.
Ellen, good morning.
Good morning. Thank you for taking the question. Thank you for doing this. On the tele-emergency service, how often do they do follow-up visits? Dr. Patel indicated he had done a follow-up visit for that patient. How often does that kind of follow-up happen?
Yeah, thank you for that question. So yeah, it is a little bit different than when you go to a physical ER, right? When you walk out, you walk out. With tele-emergency care, we actually have the opportunity. So I mentioned that our docs.
That answer is no.
X-rays or labs, and when
No.
veterans go maybe in a couple of days to get those X-rays and labs done, we actually have a system in place where we can do follow-ups on those patients. So I can get you the numbers on how frequently.
Are you going to update your profile
each
picture,
particular
Tom
case.
Bombadil,
But since it's
to the live action
virtual, it's
Rings
really
of Power
easy to
version
get them on
of Tom
phone and
Bombadil?
explain
You're
the results
keeping
to them,
the
and we
what is
kinda
that?
do
The
that check-in that,
70s
the
version,
veteran
80s
deserves.
version cartoon?
So is follow-up only when labs are ordered? Because you indicated that you followed up to see if he was okay with his change in meds.
Right.
There was no lab ordered.
Right. And so there's some patients we just want to, do a double check in to make sure that they're okay. And so the doctors have the discretion of adding patients to a follow-up tracker where we can then do a follow-up phone call and check in on patients.
And the doctors who were doing the teleemergency visits, are they located in the same VISN, or, you know, might New York be dealing with California in the middle of the night? type
Yeah,
thing?
really good question. So for most of our programs, the doctors are based within the regional network, the VISN, that the patient is in. And so they're seeing, you know, it might not be in the same city, but they're doctors generally in the same region, and they have access to that veteran's medical record.
Yeah, right now
Okay,
it's
one
very
last
heavy
question,
into
then I promise I'm done.
VHA side of the house, especially
If
with
you're
Dr.
in the
Patel
VA
there.
system, wouldn't the VA doctor have access to the medical record regardless of where they're located?
Yes, they would. So again, that's the beauty of this system is that, you know, the
Congrats
docs can
to
be
you.
anywhere, and the patients can be anywhere in the U.S. and we can take care of them because we have access to their records.
Okay, thank you so much.
Thank you.
Thanks for the questions, Ellen. We
Hey,
miss
can I-
you.
can
We
I
miss you in
just
the
say-
room.
Can I just say
Of
something
course.
to Ellen? Ellen, I think those are like super interesting questions. I do think it's worth this issue. So each of the VISNs has a what do we call them? The regional contact, the clinical contact center. And you know, there's going to be, and oftentimes, you know, we've talked about that in here. In fact, we had the head of the Boise Clinical Contact Center as a presenter here a couple of years ago, and he kind of oversees the entire clinical contact center program. But there, over time, we got to resolve an issue, which is, you know, because sometimes there's going to be a specialist available for telehealth from a different VISN. And that, for budgeting purposes at VA, I'm just responding, given this expressly to you, because you understand, I think, uniquely how the VERA model works and how our funding works. It just introduces a very interesting concept, which is we're going to be then having a vet. There are instances where we have a provider in one VISN providing care for a veteran in another VISN. So how that gets scored for purposes of the next fiscal years or 2 fiscal years hence budget is a really interesting question. And so I'm sure other systems are dealing with this in some ways, but I think this is a uniquely VA issue on our budget that, you know, it bear watching from, you know, your vantage point over the next couple of years, because I think it's a thing that we're talking to Congress about. Mostly we're talking to inside VA about, in terms of making sure that all of our tools reflect how we give care in 2024 or 2025, not how we used to give care and how we used to finance care.
One day I want to talk to you about billing Medicare too, like a former VA secretary had recommended.
Yeah, well, we'd be more than happy to talk to you about that, and hopefully you'll be hearing more about that.
That was a funny comment.
Thank you, Ellen. We'll go to Patricia.
Thanks for doing this. I appreciate it. Doctor, you just about the tele-emergency health care. You mentioned that it wasn't perhaps completely nationwide. Did you said something about like hoping that you will expand it? Can you go into some more details about where exactly it's available and what are your hopes for expansion if it is available already everywhere?
Thank you for the question. Yes, I should have been clear. It is available throughout the nation, so it's available through all 18 of our VISNs. What we want to do is be able to increase the capacity in this coming year so that we can handle more patient calls into the system. So again, we're going to be assessing veteran demand for the service. And now that we are able to share the good word that this service is available, we have a job to do with capacity management. So it is right now available throughout the nation, and what work ahead is really trying to make sure that we meet the capacity and the demand that veterans show for this service.
And if the doctor deems it's an actual emergency, do they have the capability to dial 911 for the patient?
Yeah, so that's what's really cool here is that sometimes we do get patients who, we assess and we say, look, that you really need to go right away. And the system that we use is connected into the 911 system. So patient's location is verified. And so we know where they are and we can activate what's called E911 on their behalf and stay on the phone for them with them until EMS resources arrive.
Thank you so much. Another question about the outreach effort. I don't know who wants to handle that, but the text messages, can I get
Nice.
some data on how many text messages have gone, how you are getting the phone numbers? And I understand you might be on Afghanistan veterans at this point. Is this like Afghanistan era, or is it like all veterans? Who are you really specifically doing the outreach on?
Great question. So we have, since March 5th, which is when we expanded access to VA healthcare for all toxic exposed
Afghanistan
veterans,
era.
working through the different cohorts of veterans. And so first we started with Vietnam and Vietnam era veterans. Then we moved to Gulf War veterans, Iraq veterans, Afghanistan veterans, and Gulf War veterans before Iraq and Afghanistan. We are right now in the process of finishing up the text message campaign to Afghanistan veterans and then transitioning to Iraq veterans very soon. We did a text message campaign. It was kind of our first pilot campaign last year, but the main effort has been since March 5th of this year. And since then, we've sent 4 million texts and emails to those cohorts of veterans. And we can't measure every outcome that comes from that, but we do know that directly from those outreaches, we've had nearly 50,000 veterans enrolled in healthcare, and we've driven over 114,000 disability benefit, either full claims or intents to file a full claim. And so we are continuing to move through that list. This is the result of data that we have collected over the years, as well as some data that we've securely purchased, which we manage securely in our systems. And what that has allowed us to do is get the most up-to-date information about veterans who deployed to those conflicts and served in those places, but had not yet come to us for healthcare or benefits. And those are the folks that we've been focused on. So it's folks who are currently unaffiliated with VA who could most benefit from either submitting a claim or getting their healthcare from VA. And we've been focusing on bringing those people to VA for the very first time.
And if they read about this and didn't get a text message, where should they go for to find out more?
I would encourage any veteran to go to va.gov/PACT or call 1-800-MY-VA-4011, and we will get you all of the help and the support you need. And on va.gov/PACT, it very clearly delineates who is newly eligible for PACT Act and what new benefits are available as a result of this new legislation. And if you submit a claim, you can submit a claim for far more than the PACT Act as well. So you can submit a disability compensation claim there, but you can also learn how to enroll in VA healthcare.
And
Thank you.
what's
Can I just follow up on two things that you asked Dr. Patel? During the course of this year, we've expanded
I'm gonna-
vision, the Tele.
How crazy is it that we just had a 20+ year, and I'm not even talking about pre-Iraq, like original Gulf War, Shield Storm. We just had a 20+ year war on terror, and we talked about Iraq, Afghan, but there was Syria, Somalia, all throughout Africa. And veterans don't know about VA disability compensation or VA healthcare. Simply don't know. I understand that the VA is trying to do their part, but the DoD, I mean, come on. We have TAPS and TRS, but those are absolute dog water, in my opinion. Just insane. It's insane.
Secondly, we were talking with Dr. Lieberman today. One place that this will end up being very, very attractive.
Yeah, they won't do that.
Is for our Native American veterans.
They won't do that
And,
at all. And yes,
rural
the questions are scripted.
And so I just happened to be meeting with the director of IHS this afternoon, and it's one of our periodic check-ins. I'll chat with her about how we begin to explore that.
30 years.
But that's another example of how we are thinking about this, not only as a geographic expansion, but also with a particular target to, I guess it's still a geographic function, but to veterans in highly remote areas.
You just reminded me of a follow-on. Dr. Patel, you might be able to answer this. Is there a civilian like model for this, or is this completely novel at VA?
Yeah, so this another great question. So there are healthcare systems out there that are doing, virtual care options. What we're doing in the VA, something to this scale, to my knowledge, is unique. And the fact that we get to do it in an integrated healthcare system, I think, is also unique, right? We can take care of the veterans' whole health needs, as opposed to just kind of the acute issue and then, hope that they get care later on. We can help connect them with follow-on care. And so that's what's unique and special about the VA teleemergency care program.
Thank you very much.
Thank you, Patricia. We'll go to Orion.
Everything's perfect at the VA according to what I'm seeing.
Thank you, Terrence. Mr. Secretary, it's good to see you. As you know, OIG put out a couple of reports earlier this week dealing with the EHR program. I'm looking forward to talking.
Oh, whoops! I took my headphone out. Sorry. Play.
Talking to Dr. Evans soon, so I'm going to save all my.
I'm going to go back to
questions
live.
About this particular challenges that VA faces in rural settings, in terms of staffing and access to care, things like that. But in this report, staff at those two medical centers called attention to the EHR's impacts on both revenue and staffing there, especially in primary care, where they've lost staff. We've talked before about the budget challenges, the strain on Vision 20's budget of the EHRM program. I just wonder, in light of this latest report, is there anything VA is doing to make sure that those veterans at those locations and that in Vision 20 as a whole don't see any impact to their care?
Yeah, thanks very much. Obviously we take the IG reports very seriously, and you'll have seen in there that we concur with the recommendations that the IG makes. And as I've
IG been slamming the VA, man.
Directly to the IG, I think their work makes us better, and I think that's true in the case of the EHRM.
I have been good. Thank you.
We do know that it's been the case in VA, as it has been the case in other healthcare systems, that the initial deployments of new EHRs leads to productivity loss. We try to make up for that with staffing enhancements.
I have a video on this coming out soon. The EHRM sucks really bad. Really bad.
Those are all those experiences now enhanced by the lived experience of Vision 20 and Vision 10. Those estimates and those planning parameters are updated. So
that's what they're talking about right now on the West Coast.
So at its heart, I think the plan is built around a concept that the veteran and their access to care should not suffer, that the veteran, in fact, the whole purpose of the deployment of a new EHR has to be focused on veteran outcome. That's the whole purpose of it. So that's a longer way of saying.
I have a 988
way is yes, there
video coming soon.
Steps in place to make sure that the veteran and their access to care does not suffer as a result of the deployment of the new system.
So that is what's happening. I understand that he said his goal, but it is affecting healthcare. It is, according to the OIG.
Mostly about the period before Oracle's acquisition of Cerner in 2022, but it does deal with some major incidents since then. Just briefly, what's your assessment of Oracle's performance in reducing those, even if there have still been some technical problems with the system?
I think the best way for me to answer this question is to say that, as we've relooked at the contract with our partners in the course of the last couple of years, we've highlighted system reliability as a key measurement. And we've ensured that there are ways for us to extract penalties when from the contractor when the performance is not what veterans are right to expect it to be. So I don't have anything to say beyond that, other than that, meaning this is a very valuable measure. It's a measure that we take very seriously, and it's a measure that we've now built into the contract so that everybody understands that performance is the name of the game, because the whole purpose of doing this is to improve veteran outcomes.
Thank you, sir.
Thanks, Orion. We'll go to Jory.
Hi, thanks so much again for doing this. Follow up to Leo's question about the workforce and the budget shortfall situation. We've heard from Dr. Ellenhall a couple of times now, briefing us on increasing productivity of clinicians through things like the access sprints, getting more appointments per clinician out there. He's also said about the need to increase the VA healthcare workforce by about 5,000 employee headcount for, I guess, the next year. Do you get the sense that VA clinicians are maximally productive? I know there's that balance between that and burnout. Are there future access sprints in the works here? How do you balance those two things going forward?
Yeah, I mean,
Okay. So first, that doctor's name he said, Dr. E. Ellenhall, he's the person that really is to, at least from what I see, to blame about the bonuses, the critical skill incentives. When VA Secretary McDonough was being grilled by Congress, Congress really wanted Dr. Ellenhall versus anyone else.
and you know, he's
Dude,
not
thank you very
getting
much.
productivity
Appreciate that.
points for
And our
being
new
here with
member,
us.
Jamie Hing.
Anytime you're with me,
Cock,
that's
welcome.
to be understood.
Make sure you download
You
Discord,
gotta,
dude.
Really invest in making me understand something. So we ask a lot of our providers, and we have asked a lot of our providers going back to 2019
Very
with the Mission Act,
costly. Billions.
2020 with the pandemic, 2022 with PACT Act. And our providers have, taken on each of those major challenges and succeeded very, very well. And by the way, throughout that, innovating in the kind of ways that Dr. Patel has just talked about. So part one of the answer is our providers are really good. Our providers are particularly good when we put veterans at the heart of what we do.
Thank you.
Right. And we see that time and time again. And we will continue to demand that of our providers. And that's not a hard demand, because that's what the providers want to do too. 3, because of what we anticipate will be increased demand from veterans.
I don't know why I didn't
because
before.
of the fact we've talked about this a lot this course of this year in light of the budget agreement from last year. With the introduction of the caps, there's going to be tougher budget years. So we have to be doubly careful about
I
that.
did
So
not.
we have introduced.
But how do you know I like
productivity ratings, and I
non-party?
think our
Do I
providers
know
have
you?
responded very, very well to that. I guess the reason I answer the question that way, Jory, is that I want you to understand, and I want our providers to understand that.
He's not saying anything important right now. Tom, thank you so much, dude. Absolutely. You don't have to do that at all. I don't even know what to say. I feel very awkward. Thank you.
Each of those 3 major system
providers
are going to step up on this as well.
Talk baloney about
we're
it.
seeing
okay.
clinics on nights and weekends. I've told you I was already about a radiologist I met down in El Paso. I met him I thought it was pretty early. Right? I met him at like
wild. Thank you, Tom.
7:30.
Tom Bombadil. Question for you, Tom.
Providing radiology services.
Here, he's still not saying anything. Whatever he's saying is useless. Tom, do you think Tom Bombadil is Tolkien's ideation of God, or input of God into Lord of the Rings lore, or do you think Tom Bombadil is Tolkien himself, kind of in a form of like humility of saying, hey, he's the creator of Lord of the Rings, but he doesn't want to put himself on the same level as the creator of the universe, right? Because Tom Bombadil was a devout Catholic. And a lot of people do say that Tom Bombadil is Tolkien's version of humility when it comes to Lord of the Rings. Just food for thought. You don't have to answer that if you don't want to. Okay.
By the end of FY25, which was embedded in the FY25 budget, is too little. So we said, look, we think it works, but if we
It's
need
just on
more,
the
we'll
West
come back to
Coast.
talk to you.
There's
The
5
one thing we will not do
facilities,
is we will
VHA
not
side of the
stop
house.
the outreach to the veterans that I have talked about, because
J
this is their
Suite,
care
but that
that
shouldn't be
they've
an
earned,
issue.
and we have to make it available.
To
So
my
if we need
understanding,
more
that shouldn't be
providers
an
to make it
issue.
available, we'll let you know, and we'll ask for more money. Well, we
Dude,
did,
right?
and so inside the 12 billion, we would no longer be going to status quo ante, which is 383,000.
I need to get back to pinning
We'd be going
this
closer to something like
message I meant to pin.
404,000, right? So now those numbers are going to be constantly updated, right? And especially with the end of the fiscal year, we'll have some accounting to do over the course of the next several weeks. So we'll take a hard look at that. So I can't entirely answer your question about how contingent it is, but that gives you a band, right? Status quo ante would have us go to 383. The additional funding, the additional TEF.
It can't be. The Hampton, Virginia Medical Center just went through some crazy stuff. I have a video on that coming out too. Hampton VA Medical Center, whole staff, senior staff rework.
About the VA
So it's-
healthcare workforce exceeding
It's impossible.
400,000.
Yes.
And what you're saying now is that the headcount has gone down somewhat. So we're no longer at that peak VA healthcare workforce that we saw earlier this year, just through attrition.
You know what?
retirements?
You know what? Rather than answer that question, because I think you're asking for a degree of precision that I may not have, and
Yeah,
as
nice.
a result, I'll probably answer incorrectly. Let us take that and get that to you guys through Terrence. Kind of what numbers have been at different snapshots during the course of the year, right?
Yeah.
Because remember that I think we ended 23 at something like 390,000, which is why we thought we could get to 383. During the course of this year, we continued to add, right, off of the base at the end of 2023, fiscal 2023. So what exactly that was and has been at different intervals, we can get you that, and then you can just draw your own conclusions from that. Does that
That'd
sound
be great.
good?
Thank you.
Good. Thanks, Jory.
Thanks, Jory. We'll go to David. Good morning, David.
Good morning,
Terrence.
David.
Mr. Secretary, good morning. Not that I don't want to speak to Terrence, but so I'm sure you're a little relieved, as everybody is in the government, we're not having a shutdown, but to the 12 billion and to what Jory and Leo have been talking about, do you think once we're past the election, maybe there's a little more wiggle room for Congress?
Yeah, you know, I'm David, I'm going to let Congress speak for Congress. And I just tell you that, you know, they have questions. We're answering the questions. They've been great partners, obviously, to us. So I'll let, you know, we'll keep answering the questions, keep doing the things that we're doing. Most importantly, we're going to keep the outreach going, and we're going to keep the focus on access as tight as it has been. And then we'll resolve we'll work with Congress to resolve the issues then when they come back.
Mr. Secretary, I'll speak into Congress. Ranking Member Takano put in a bill about
I got you,
Title
dude.
38
It didn't
collective
pass.
bargaining the
That's
other
all right.
day. He's always bragging about being the PACT Act guy. I wonder what your reaction was to that bill.
Haven't seen the bill, David. I think he's done a version of this bill in the past, but why don't I get you our position on the bill through Terrence so that I don't give you the wrong answer, because I might be confused.
You know, food for thought. This dude's sitting in his bed.
Different bills, but as
Maybe a
general
hotel
matter,
room.
We do believe that collective bargaining is an aspect
Come
of
on,
a
man.
strong workforce.
Straighten yourself
But
up, big dog.
that particular bill, I'm sure we have a view on, and I'll let you know.
That's great. If Terrence could get that and the other information you just mentioned with Jory today, because I'm sure we're all on deadline, that'd be awesome. And if you could give Mr. Stecker, you give Terrence a hug because the Jaguars are not doing well.
Yeah, I don't know if you saw that the Vikes are 3-0, but anyway.
No, we
next
did.
question.
Yes. Congratulations.
Yeah, thank you.
So now we got reporters tasking me and giving shots at me. So I enjoy that. Jordan.
Hi, thanks for doing this. I had a question for Dr. Patel. I'm curious if there's, with the Tele emergency care service, if there's synergy between existing
None.
VA programs. I'm specifically thinking of the Uber Health Connect program, which you know is tasked with giving rides to veterans to get to their appointments. Is there any synergy? Will these programs sort of work together?
Yeah. Again, thank you for that really great question. So as right now, that's work that we need to do in FY25 to make those connections. We are aware of that, and that's a very interesting kind of connection that we want to make. We're also using,
You know,
this
the issue
service to
with these, I
support,
mean, he's saying
taking
nothing
leave
right
on
now.
elderly.
The issue with these press conferences is, and same thing that we saw on the House Veterans Affairs Committee that was being briefed, the CMP rep or whatever his title was. According to the VA is perfect. And I'm not saying they don't do good things. The VA does a lot of good. But whenever the VA completely ignores the bad and they only talk about the good, which is what we're seeing here, it really brings, at least in my mind, it shines light on the bad versus the good. The good does not outweigh the bad, and the bad doesn't outweigh the good. Both things can be true at the same time. But if you only talk with people who you agree with, this is what you get right here. You get press conferences
So
where
the majority of
everything
patients
is
in
good.
emergency care services
Don't
are
worry,
actually
guys.
over the age of 65.
Everything's good.
Get you data on the kind of geography spread, rural versus urban, offline.
Great, thank you.
Some of that data might be skewed so far because we have not yet been, until
Yeah,
now.
I'm about
we have
10
not
minutes
been
south of
measuring.
DC myself.
So the data that you'll see on geography will reflect, it's like looking under the lamppost, right?
No
Now
movement on
we
that
turn
at
on
all.
the lamppost, we'll get a better handle on it.
Thank you.
I think Dan's on the call. Over to you, Dan.
Thank you, Terrence. Mr. Secretary, I have a couple of questions about the VA's proposed rule for constrictive bronchiolitis. Can you tell me how personally involved were you in the issuing of that rule that created a new code for constrictive bronchiolitis? Were you briefed on the criteria for what the criteria would be for the sake of establishing disability benefits?
See,
Yeah, so, all of our
great question.
rulemaking is published in the Federal Register under my signature. So I was
Great question. However, turn that to mental health and sleep
So I was
apnea,
looking
and
at
now
the
we're
comments
talking.
earlier today. There were 38 comments. Most of the comments are, praise the VA for establishing a code, but they criticize the VA for the criteria for assessing benefits. The proposed rule, as you know, calls for using pulmonary function tests, maximum oxygen consumption, and metabolic equivalence. So, Mr. Secretary, what do you say to the people who put in comments that say those tests are insensitive and can't detect that condition?
I say it's awesome that they're using the public comment period to add comments. And, the way this works is when the comment period closes, then we'll respond to those comments and we'll use those comments to sharpen the rulemaking. And so what I say to them most profoundly is thank you.
You don't have any initial reaction to their comments?
Now I want to be really careful to be respectful of the process here. Dan, you and I have had an ongoing conversation about this, and the Administrative Procedures Act does lay this out quite clearly, what I can say and when I can say it. And I want to not compromise that because it's been a long time in coming, and I want to make sure that we get it done right for those veterans who are suffering with this. I will say that I'm really happy to see that to date grant rate on veterans filing on CB is north of 75%. That's
Sorry,
positive,
what do you mean by that?
but we want to make sure that we stay, that we get this in a position to get every veteran the access and the benefits that they have earned.
I'm sorry, when you say 75, north of 75%, explain that. I don't understand.
Yeah, he's the PACT Act. That's,
Veterans who are filing claims.
come on, dude. Come on, you're a rookie.
On constrictive bronchiolitis are being awarded, I'm told by VBA, at 75% grant rate.
So you're saying 75% of veterans are getting a grant, are getting a benefit, or their benefit rating is 75% or more?
I'm saying that of those who file a claim, I'm told by VBA, and we'll get you the data, Dan, of veterans
that part
who
is
file
true.
a claim for constrictive
It's just this guy doesn't
bronchiolitis, that
understand what
claim
the
is being
VA secretary
awarded
is saying.
in the veteran's favor 75% of the time.
But you don't know what the rating is. I mean, the rating might be 0, but they're getting an award.
You're understanding my answer. Yes, you're understanding my answer.
Right. And just last question, and I'll let you go. So the idea, the criticism that you're using an insensitive test as a metric for rating this condition, what's your response to that?
The criticism and the input is going to be something that we will address when we respond to the proposed comments. 1, 2, the issue of how one measures how one diagnoses constrictive bronchiolitis is an issue that we have been wrestling with, and critiques of us are expected, meaning and helpful, because we aspire to be a veteran-centered organization. And so again, the way I respond to those critiques is to say, we hear you. This is really important to figure out how best and most accurately to make this diagnosis. And most importantly, we want the veterans to get the care and the benefits that they have earned.
Okay, thanks.
Mm-hmm.
Thanks, Dan. We'll go to Quill.
Well, at least what's his name? Dan? At least he put him in a hot seat.
Thanks very much. Should let Adam know that our Boston affiliates will be investigating the attendance of a Red Sox Nation member at a Yankees event. Just automatically trigger the investigation. Fair warning. But my question, of course, is about VASP, which is rolling out next week. This week I was in Oklahoma meeting with a former MP who served in the 90s, survived MST, took her decades to sort of claw her way back to a good place, part of which involved a VA home loan. And then because she had to take care of sick relatives during the pandemic, she took a forbearance, and then got a call about a year later, as many other recipients of the VA COVID forbearance did, and said, where lenders basically told her she had no choice but to take a loan modification or pay all of her arrears at once. She took what was a 3% loan and ended up with a 7% loan, raised her payment by 50% on her teacher's salary, and now she's on very shaky ground financially. The VASP program, which is coming out next week, as written, it does nothing to help her. So she wants to know, what are you going to do to help veterans in her situation who were, as they consider, duped into taking this VA forbearance, which had no on-ramp back onto solvency, and the current fix doesn't seem to affect them. And do you know how many people are in her situation?
Yeah. Well, thanks very much for the question, Quill. Since we last talked, we've obviously continued our work to ensure that servicers participate in the moratorium on foreclosures, and that we are continuing to work the VASP program. You and your teammate have done really important reporting on this, including in this case with this veteran, teacher, loving family member. We are working all that data through. I don't have an answer on your question about similarly situated veterans. That is to say, I think what you're saying is veterans who refinanced and now find themselves in an unfair loan situation. We can aspire to get you that, but we are very focused on October 1. And when we have, if we have any further announcements on the aspects of VASP, we'll make sure that we make them, and you will be among the first to know. But I don't have any news for you on that right now.
Okay, I mean, because this is, in the year after the program ended, before we started talking about it, which is about a year ago, there were people like her who didn't get a chance to take advantage of your moratorium, which you put in place right away.
I understand. I understand. I understand. And what we really want to do is make sure that we're going to have the program reflect the most veteran-centered way that we can have it to address this range of questions, Quill. And what I want more than anything, on top of addressing our veterans' concerns, is to talk to them directly so we can hear them, so that we're not doing this by analogy or not doing this by, as good as your reporting is, I would love to talk to those veterans directly about how we can work with them, in which case I would ask veterans to contact us directly at 877-827-3702, and then pressing 4. That's 877-827-3702, and then exercising option 4, or by visiting us at the VA Home Loans site for additional information. It's not to say that we don't value your reporting. We do, and we'll try to get answers to your specific question here. But we're also very focused on October 1 and making sure that this is ready to go.
Right. I mean, respectfully, I have been asking this question to your staff and to you in press conferences now for months.
Yes.
I don't get the impression that VA is aware of how many people are in this situation. I mean, we've been asking for months. So
yeah,
I don't know. We have a data dump, but we don't have a way to analyze that data. We've also been asking for clarification on that data. Mm-hmm. This, I wouldn't normally call this out in a press conference, but I have been asking by email and text for months.
Yep. And you're asking specifically for the numbers of veterans who are in, who have refinanced into loans that are difficult to maintain. Is that correct?
We're given, essentially we're given an ultimatum, pay everything or take this really devastating modification to the loan that VA gave you. Right. And again, these are people who are being punished because they're veterans. If they had a Freddie or Fannie loan and forbearance, right, this wouldn't have happened to them. And I really want to know if VA knows how many people are in this situation. And if you know, I'd like to know how many. Good. And I'd like to know if there's anything in the works, because VASP, as you wrote it, is doing nothing for these people. So I understand that that's going to roll out next week and help the people it helps. But VASP, as you wrote it, very clearly does not help these people.
Right. So I want to be responsive to two things. One is you want to know the number of veterans who have been forced by private lenders into very unfavorable,
a loan mod. Yeah, a very unfavorable
loan modifications. And it sounds like we gave you some data, but you want more clarification on that. I'll make sure that Terrence and our team work with you. Question 2 is what precisely VASP does for veterans. And as I say, we've talked with you about this, including I've talked with you about this in our monthly pressers. And I know that we've had, Josh has talked with you as well, and John Bell and others. we're we're fast approaching October 1, and when as we have new information to share on that, we'll share it with you. So one, I want to get to your answer on our best sense of the number of veterans
Congrats to you.
in that difficult situation. We'll do that. Number two is, as we approach Tuesday, as we have new information, we'll share that with you. Three, and most importantly, to our veterans, we really want to hear from you. And so we urge you to be in touch with us directly.
Congrats.
Even as you, as we continue to value the reporting, Quill, by you and by your teammate, Chris.
And Chris happens to be here with some follow-ups if when Terrence is ready to call him. Thank you very much for doing this. It's good to see you all.
Over to you, Chris.
All right, great. Can you guys hear me?
Yes.
Yeah, and just Quill said almost everything very, very well. Just to underline that, I mean, these are vets. We're talking to this vet, Natalie, is her first name. We were just talking to in Oklahoma. And, she really does feel betrayed. She was told to take this help. She was helping a family member die, during COVID. And then she had the rug pulled out. And again, we want to know how many people that is. And also, I guess my question is, why does the current VASP architecture of the program not help people like her? Is it a worry about cost? Because if we don't know, well, maybe it's just a handful of people. And if it is, probably wouldn't cost that much to help them. And they feel like, she's saying, please help us too. She just wants some semblance of what her life was before. She's worried about having to stop being a teacher. She really can barely afford her mortgage and is going to have to give that up and do something else. And or if it's a lot of people, we find out, well, that sounds like a really big problem. Maybe that should be fixed. And why is it that the current program doesn't help people who went into this in good faith, got blindsided by a much more costly loan mod? Again, if it was a Fannie and Freddie loan, an FHA loan, there were better options in their loan mods. But VA loans, these folks were punished, like Quill just said, for having a VA loan. There was no option after that PCP program ended.
Yeah, Chris, I think, Chris, I think, we've had you, myself, Mr. Jacobs, and other members of Team VBA have this conversation quite often. We've shared with you the data, and we'll get to hopefully a more precise conversation so you can understand what the data states. But I think from those conversations that we've had is that, one of the things that, that was explained by Mr. Jacobs and his team is that, various veterans take mods for various different reasons. So that was one of the issues that was brought up in our earlier conversations. To the veteran that you talked about earlier, as the boss said, our hearts go out to her in her situation. What we want and what we encourage her and others who potentially might be in a similar situation is to please give us a call first, as early as possible when they may be facing any of these potential challenges, so we can hopefully come to a collective solution alongside them so they don't take these mods like you're stating today. So again, that's what we're trying to do on the prevention side of the house. But again, we'll dig into deeper on the numbers and to ensure that you understand what the numbers are that we've provided you and Quill. But again, I think just reference back to Mr. Jacobs, and he's going to have another roundtable coming up soon. And of course, you can float that question back to him. But again, I think we've had those conversations, similar conversations on the differences in mods and how it's hard for, I think, VA or VBA, that is, to determine, what was a mod, as you reference, with this particular veteran, and just say a mod from someone else who may just take a modification or refinance or whatever the case may be. So we can circle back on this, though.
Well, just to be clear, though, I mean, you could very easily, I would imagine, define someone's in a forbearance, COVID forbearance with VA loan. They wound up in a loan mod that was significantly higher cost because the interest rate went from 3 to 7 or something. It's not complicated. It's like, well,
yeah. Again, I mean, we've had the conversation over there, and as boss said, he's tasked me out to circle back, and that's what I'll do. I'll definitely circle back with both of you gentlemen to ensure that we can get clarity on the information that we provided you.
Okay. because like Quill said, it's been 9 months, and just even to get a subject matter expert on the phone to be like, what's in the database?
We've hold on. I want to make sure for the record, we have indeed provided you and Quill several opportunities to chat with our team, and we'll continue to do that transparently as the boss demands of me. So again, I will circle back with both of you to get the information that you request.
Okay, thanks, guys.
Appreciate you. With that, do we have any other questions? Well, before we close, I think the boss wants to close out with some great news from our colleagues at Team VBA.
Yeah, so let me just say to the team about our team at VBA. For the first time in VBA, first time in history, VBA has processed more than 11,000 claims in a day.
Oh my gosh, here we go. Read the script.
The second time they did that,
Veterans are getting more benefits than ever before.
So they turned right around and broke that record. So our teammates are really doing important work delivering earned benefits to veterans. So I thank them for that. But also recognize that, look, our veterans are still waiting. So let's get those claims worked. And just for purposes of completeness, the disability compensation backlog today is 241,075 claims. That's down about 30,000 since the last time we were together. So continuing to make progress. The most important thing I want to explain here is to veterans, please file claims. These are your benefits that you have earned. So let's make sure that we get you those benefits. The first step in doing that is filing a claim. So thanks a lot, everybody. Appreciate you.
Thanks, everybody. We'll see you next time.
All right, dude. So here are my thoughts, okay? And then we'll kind of end the stream with this. The VA always talks about how great the VA is, and CMP questions always get skipped or just not asked, not answered. There's really just no... I guess what I'm trying to say is that I think it's a big waste of time, okay? I think it's a big waste of time. It's like softball level questions, lots of VHA, which is all important, but there are elephants in the room like CMP exams, unwarranted CMP exams, companies targeting veterans, right? The VA home loan issue with the foreclosures, all that is important. The only really one good question we had was from that Dan dude about the constructive bronchiolitis, which is essentially the VA's proposed change is to add a diagnostic code. And you know how GERD went from, here's what we're going to rate GERD off of these symptoms because it's analogous. It's like these. And then they have their own diagnostic code for GERD. And now GERD is esophageal stricture. And that is very strict, pun there. Same thing with bronchitis, okay? So they're making constructive bronchitis its own diagnostic code, and instead of it rating things like other things except for constructive bronchitis, they now are going to have their own rating criteria for constructive or testing for constructive bronchitis, which is more strict. All right, that's all I got. Tom, dude. Tom Bombadil, man. Thank you very much. I definitely appreciate that. And y'all have a good evening or good afternoon, good morning, whatever. I'm working from home today, so I'll be doing some videos. Later.